you'll see how these V1 comes up on the top of the scalp, and then you've got the cervicals back in the back. So that's what I was talking about earlier, C2. Okay? The blood vessels of the scalp are just, the scalp is heavily supplied by blood vessels. From the supraorbital, supratrochlear from the front, to this large one here, the superficial temporal artery on the side. That's the one that you can feel the pulse right here in your temporal. When you lie down sometime, you can feel you can hear the boom, 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 that's part of that. And then you have the occipital. Back on the first day when we were dissecting, remember I told you there's a little vessel that came through the muscle back here. It actually comes out of the suboccipital triangle. That will be the occipital artery. You can find it back there. Trace it all the way up onto the back of the skull. Okay? You don't need to find these today. We will find the superficial temporal. It's large and very superficial, as the name implies. Okay. The vascular supply of the face, you're going to find the superficial temporal right here. That supplies this part of your face. There's a small artery right here called the transverse facial that runs across the masseter. It's superficial. It's actually pretty small right here. Transverse facial. You have the supraorbital, infraorbital, and mental arteries. And then you have the large facial artery and vein, especially the facial artery arises from the external carotid, crosses the mandible, and ascends up to the angle of the eye. The end of it, you call it the angular artery. As it travels up, it gives off two labial branches, a superior and an inferior. This supply the upper and lower lip. Gives off a nasal branch, and it ends at the angular. You'll see that in other slides. The facial artery, again, is the one you can feel the pulse there on your mandible as it crosses. The artery typically runs deep to the muscles, as you see there. The vein is sort of in and out. Some it's superficial too, some it's deep too, that you'll see there. The vein may not be obvious when you dissect. The artery absolutely is. Now, one thing about the vein, though, the facial vein, is that it communicates with veins inside the skull. So if I go to the next slide right here, here's the facial vein. It communicates through the orbit with veins inside the skull right here called the cavernous sinus. You don't want to put infection into the cavernous sinus. Therefore, this area of the face is known as the danger area. Right here, because of that connection inside your skull. When you were a little bitty teenager, it says right here that your mama told you not to pop zits in this area, because if you wind up with a cellulitis in this area, which is a staph infection here most likely, it can take that infection inside your cranial vault, which is not a good place for you to have infection to reside. The place that it resides is the cavernous sinus. So no picky zits in that area. One thing that this illustration shows you is that whenever you encounter a cellulitis and you start treating it, get a magic marker and mark the outlines of it. So when you check them back the next day, you definitely don't want it to have extended. You want it to be lessened with the antibiotic you have now placed them on. Okay. Any questions about that?
What did you call that?
What's the triangle?
Danger triangle, the no picky zit triangle, whatever you want to call it. It's just the central part of the face. Now, we know that the trigeminal nerve innervates the muscles of mastication, and the seventh cranial nerve innervates the muscles of facial expression. The seventh cranial nerve arises from also the pons. It's illustrated there in yellow. It exits the cranial vault, gives off several little branches that we're not going to worry about, but exits the stylomastoid foramen at the base of the skull, which is right here, right up underneath there. There's my mastoid process. So right behind my mastoid process is the stylomastoid foramen. Once it comes out, it moves forward, and right here is your parotid gland. It branches into 5 branches through the substance of the parotid gland. It's actually, the parotid gland sort of grows up around the nerve fibers. The 5 branches of the facial nerve are the temporal, the zygomatic, the buccal, the mandibular, and the cervical. The cervical, of course, coming down here to get the platysma. The buccal getting the buccinatum. The temporal and the zygomatic getting up here. And the buccal and the mandibular getting your mouth, that area, right? You don't need to know which muscle's innervated by which nerve. The way you remember this is 2 Zanzibar bimotor car. That's the dumbass little mnemonic to memorize that. 2 Zanzibar bimotor car. Temporal, zygomatic, buccal. It's probably easier just to memorize the name of the nerve. The thing about that is it comes out the stylomastoid foramen, innervates the muscles of facial expression, goes through the substance of the parotid gland. Therefore, if you were going to do a parotidectomy, the thing that you're most concerned about is destruction of the 7th nerve and them losing the ability to have facial expression on that side. Most commonly injured nerve in a thyroidectomy is what?
Facial nerve.
The most commonly injured nerve in a thyroidectomy is what?
Recurrent
Laryngeal. The most commonly injured nerve in a parotidectomy is the facial nerve. Okay. Let me. Okay. Any questions about that? You'll see, you'll be able to pick out some of these fibers. They are very fine fibers, and it's just impressive to me that they do a lot of this surgery in your face and stuff, and be able to identify these fibers and avoid cutting them. It's truly impressive. The easiest one to find is the buccal branch. It's the largest branch. It goes right across the masseter. And these are superficial to the masseter, by the way. If you put everything together, this is what you got. This is what today's dissection is going to look like. Some stuff we've already seen here. Here's the sternocleidomastoid muscle. There's the great auricular nerve coming off the cervical plexus. Here the sensory part. Right beside it is the external jugular vein. That's nice. Here's our masseter muscle. Here's 2 Zanzibar bimotor car, these yellow fibers. There's the transverse facial artery. Right below the transverse facial artery is this green thing right here. It's not really green in the cadaver, but it's green on this picture. That's the parotid duct. It arises from the parotid. You find the parotid, you just follow it forward. You're going to hit the duct. You can't miss it. It's very superficial to the masseter. Therefore, if you get a laceration, you get in a bar fight, somebody cuts you right here, there's a lot of important stuff right here. You could cut through the facial nerve, branches of the facial nerve. You could cut through the transverse facial artery. You're going to bleed like crazy. You could cut through the parotid duct, all while being superficial to the masseter muscle.
This may sound ridiculous, but it's on both sides, or?
Yeah, you have a parotid gland on each side. You have all of this on each side. When this guy turns around and goes that way, you'll see the same thing on the other side. Lymphatics of the head drain, as I said the other day, into the junction of the internal jugular vein and the subclavian. Both sides.
They run into the
That is your nickname from now on.
Both sides.
To the day she graduates, her nickname is both sides. Okay?
Interesting.
You're bilateral. I mean, you know, mostly what's on one side is on the other. There are a couple exceptions. Right here is one of them. The entire body, the lymphatics from the entire body, except for the right side of the head and the right upper extremity, all of it drains into the left neck through a structure called the thoracic duct we're going to talk about in the next test block. This side just drains the right side of the head and neck and the right upper extremity. Therefore, what do you find on the left side of the neck that you don't find on the right? It's called the thoracic duct. So there's a little bit of asymmetry.
What did you say all the lymphatics drain into? The subclavian and what else?
Yeah, all the lymphatics will eventually drain into the junction of the internal jugular vein and the subclavian vein. The one on the left side is about the thickness of a pencil because it drains most of the body. The one on the right side is so small it's hard to find. Here's an example of infection or inflammation of the parotid gland, quite pronounced there. This is going to be painful. These glands have capsules around them, so any swelling causes pain against the capsule. It's not so much the gland itself, it's pain in the capsule. In an adult, if you see parotitis, the first thing you need to be thinking about is HIV infection. You definitely need to get a HIV test on parotitis, unilateral parotitis in an adult. Mumps in kids frequently. The glands can produce stones, like your gallstones. Your salivary glands can produce them as well. A stone, now that you're all grown up, a stone in medicine is called a calculus, or calculi if you're talking about more than one. You can have calculi in the ducts, the salivary duct. You see right there that little metals will glow, will be radio opaque, so they'll be white. Calcium is that. So you see a white ball there. Behind it you see the dilated duct. This happens to be the submandibular duct. The submandibular duct, we saw the submandibular gland, the duct will open up into the, and you raise your tongue up, the little frenulum that connects the tongue. If you look at the frenulum, it's got two little bumps on either side of it. That's where the gleek, the little gleek thing, that's the submandibular duct. So that's blocked over here. The opening of the parotid duct in the oral cavity is up here on the beside the second maxillary molar. Oh, right here. If you look inside your partner's mouth, you'll see a little papule there. That's the opening of the parotid duct. That opening is called Stinson's duct. That opening is called Wharton's duct. I remember Wharton's because it's a W, like the bottom, you know, like the frenulum. And Stinson's up here. That didn't make sense?
No, the W.
Like a W. Like that's your frenulum. And so there's the little things right there. It almost looks weird. W-A-R-T-O-N. Wharton's duct is the opening of the submandibular duct. Stinson's is the parotid, second maxillary molar. They actually have a camera they can put inside these, the ENTs. They can actually go endoscopically in those ducts. And there's a stone endoscopic inside the duct. They got a little grabber, they can get it and pull it out. These things are 1/2 centimeter. That's a pretty big rock to be inside your, you know what the treatment for this is? You know how you treat this?
Is it something with like Got a real sour candy or something?
Yeah, you give them lemon drops, the hard candy, lemon drops. You increase the salivation, and the pressure, the back pressure is what forces them out. They can be kind of painful. Because what causes visceral pain to become conscious?
Ischemia or
And
distension.
dilation. There you go, right there. All right. This is a laceration of the eyebrow. Never ever, a lot of times you have a tendency when you're dealing with the scalp is to shave the head or shave the area around the laceration. You never shave an eyebrow. From this day forward, you never shave an eyebrow to suture it up. You just put the pieces together and suture it up as best you can. These are steri strips. Remember the other day I was talking about the geriatric person who sutured through the steri strip? That's a steri strip. All right, any questions about that? Never shave an eyebrow. You just put it together and sew it up. This is the red border here of your lip is called the vermilion border. Vermilion is whatever for the color red. When you suture a lip laceration, the first stitch that you throw, the first stitch that you put in should be done through the vermilion border. And that way you get perfect approximation of the vermilion border. And then you suture up on either side of it. The first stitch goes through the vermilion border. Otherwise, this little kid right here, this is cosmetically not appropriate. This is a lawsuit where the vermilion border is not perfect. On that lower panel right there, you see where they didn't approximate the vermilion border and it healed, and now you've got a permanent disfigurement. The mandible has several different pieces and parts. You need to appreciate those. This is the coronary process. The coronoid process that I mentioned earlier where the temporalis muscle attaches. The articular portion is called the condylar portion. Condyle is the articular part. This is the ramus. That's the body. That's the angle right there. On the inside, there's a hole. That hole is called the mandibular foramen, and it transmits a nerve and an artery called the inferior alveolar. This part of where the teeth are is called the alveolar ridge. That's the alveolar ridge. The alveolar ridge is where the teeth insert, both mandible and maxilla. So the nerve and artery supplying those is going to be the alveolar. Inferior for the mandible, superior for the maxilla. There's a little protuberance right there at the edge of the foramen. Right there, it's called the lingula. The lingula is important because that's where that sphenomandibular ligament attaches, that attaches the base of the skull to the mandible, help hold it in place. You can feel your sphenomandibular ligament. If you feel inside of there, you can feel your ramus. Go ahead and put your finger in your mouth. That edge. Go ahead and put your finger in your mouth. I don't know where your fingers have been. Oh, yeah. You can feel the sphenomandibular ligament. Okay? You feel it? All right. The reason that's important is if you want to anesthetize the teeth, what you do is you take that needle, that syringe, you feel for that sphenomandibular ligament, and you pass the needle between the ligament and the hole, and you've hit the nerve. And you're going to anesthetize all the teeth on that side. The inferior alveolar nerve supplies all the teeth, and it exits as what? What hole is right there? The mental nerve. So the terminal branch of the inferior alveolar is the mental. That's why when you get your teeth worked on, your chin always goes numb. Oh, that makes sense. Uh-oh. All right. Uh-oh, yeah. There's the mental foramen right there. Okay? So if they're going to work on your teeth, your lower teeth, they say, can you feel this? They're touching your chin. So that's, if you can't feel your chin, then Your teeth are numb. The condylar process articulates in that notch up there. In front of the notch is a tubercle. You see that little tubercle that hangs down? That sort of keeps the mandible from sliding forward. That tubercle way up there. All right, you'll see it better in this slide right here. Here's the tubercle right there. There's the condylar process. There's actually a piece of cartilage between the top of the condylar process and the zygomatic process. There's a disc there. So that disc has a synovial space on either side of it. And that disc helps things glide as you open and shut your mouth. This is the temporomandibular joint. It's innervated, as we said earlier, by the trigeminal nerves, because it's proprioception, right? That's V3, the mandibular branch of V3. The trigeminal nerve also provides sensory information to part of your ear canal, part of your eardrum as well. That's why sometimes you get referred pain from the TMJ up into your ear. This is a dislocated mandible here, where basically the condylar process has opened up and gone in front of the notch, the tubercle. And once it gets in front, the muscles will wind up holding it there, so they'll come in a lot of pain with their mouth open. And usually it only happens on one side, rarely happens both sides. So their mouth will be open, sort of cockside, like that guy up there in the top right. You can only get these things back into place. You can only reduce these with a huge amount of sedation. You need to first make sure with an x-ray that the mandible is not fractured in any way, or the zygomatic arch or the temporal bone is not fractured in any way. Then you load them up with Versed or Demerol or Propofol or whatever you got in your pocket, and you essentially do conscious sedation. You see this guy is kind of sleepy. You stick you wrap your thumbs in gauze and stick them in their mouth, put them on their teeth, and then you push down as you push back, and you pop that thing back around the notch. It's actually pretty easy to do. You got to have them sedated though. If they're not sedated, you will never get it back in place.
When we do our dental rotation, are we going to be with like a specialist, or you're just like a regular dental office?
It's a regular dentist office, and you're more focused on the teeth rather than the surroundings, and the gingiva rather than articular structures and things like that. Why were you asking?
Oh, I was just wondering.
Yeah. Anyway,
So dentists
you
don't
probably
do
won't
this?
see somebody with that many teeth. The degree of dental disease in this state is just staggering. Who did the Mission of Mercy? Who was that? It's just staggering.
I just asked if the dentists don't do this, we do it.
Oh, the dentists won't do this. No, you do it, and you will do it in the emergency room. PAs cover rural emergency rooms. The doc is at home or not even in the same town. So if somebody comes in with a dislocated jaw, you're the one that's going to put it back in. If they come in with a dislocated shoulder, you're going to put it back in. A hip, you're going to put it back in. You call your supervising physician out to put a dislocated jaw back in place, you probably won't have a job the next day. So where'd you go to PA school?
Is it a
Oh,
lot of
you?
pressure to
Yeah, you have to get it past that.
Is it like one person?
It's just you.
Like girls can like.
You can do it, yeah. But you gotta have sedation. You really gotta have the muscle, the surrounding musculature relaxed.
So what notch are we pulling it back into?
When you look at the skull down and the thing, you'll see it. Right here, no, that's not the one. No, that's not the right one. Right here. You see, there's the condyle, and there's the tubercle. The condyle winds up in front of the tubercle. And when it does, the surrounding muscle spasms and tightens it down, and prevents you from getting it back into place.
Do these people just get hit in the face or something?
If you get hit in the jaw with your mouth open, that's why they don't tell boxers, for two reasons, to keep their mouths shut. One is you can fracture a jaw if the mouth's open, and second, you can dislocate it. I've had people dislocate their mandible yawning. Yeah, can you do
I
it?
feel like mine
Yeah,
is
I've done it in
open.
the dentist's office before.
Oh, really?
Yeah.
Yeah. So it's not hard to get it back in. Okay.
Somebody pop theirs out.
Somebody pop theirs out, come on, pop your, no.
When I open my jaw all the way, they pop out like this, but then they just go back.
Then they haven't made it all the way past the tubercle. Once they make it all the way past the tubercle, you're in trouble. All right, one of the things that, with the mandible is you lose bone mass as you age. And it's pretty startling. With that 78-year-old cadaver, you'll see once you get the mandible exposed, he or she is going to have a pretty thin mandible. And in fact, the location of the mental foramen actually moves as the mandible decreases in mass and winds up on the top. Now this is an edentulous person. They have no teeth. You have less mandibular loss if you have preserved your teeth. Okay, because the alveolar ridge is still there if you have your teeth. All right, muscles of mastication. We got now 1, 2, and we numbered them 1, 2, 3, and 4 here. The temporalis and the masseter close the jaw. 3, which is the lateral pterygoid, is the only one that opens the jaw. You can't see 3 until we remove the masseter and the ramus of the mandible. We've removed the masseter and the ramus of the mandible. No, the mandible's still intact right there. There's the coronary process. There's the temporalis inserting into it. There's the notch. There's the condylar process there. In this illustration right here, we've removed the masseter and the ramus of the mandible and the zygomatic arch. You see right there is the lateral pterygoid, right there, and then the medial pterygoid is up underneath here. The medial pterygoid, in this illustration right here, we're on the inside of the mandible looking out. I mean, inside the oral cavity looking out. So there's the medial pterygoid right there. There's the ramus of the mandible. So you think of it like this. The masseter comes on the outside, the medial pterygoid is on the inside, and together they form a sling to help close your mouth. The only one that opens the mouth or protrudes the mouth is the lateral pterygoid. You see, if you took that process and this process and bring them closer together, you're going to come together here and drive the mandible down in the front. So the only one that protrudes the jaw is the lateral pterygoid. If you want, I can cut into here and show you these pterygoids. If not, you will probably never see them clinically. So that's why it's not part of the dissection. All right, but there's a couple of nerves, though, you need to be aware of that are right on the other side of the ramus of the mandible. That nerve is the lingual nerve. The lingual nerve provides somatic sensation to the tongue, to the anterior parts of the tongue. Anterior 2/3 of the tongue, to be precise. The lingual nerve. So if I touch your tongue, that's the lingual nerve. The nerve right beside it there is the inferior alveolar nerve. That's the nerve that goes through the mandibular foramen. That's the one that innervates the teeth. So remember that dentist is trying to get right here. He's trying to get to that nerve before it goes through the hole. And so he or she infiltrates lidocaine into this whole area here. So what happens? You anesthetize your teeth, all of them on that side, right? You anesthetize your chin, because that's the termination of that inferior alveolar nerve, is the mental nerve, right? You're also going to impact that nerve because it's in the area. You're gonna get the lingual nerve, which supplies sensation to your tongue. Remember, your tongue goes numb, right? Two other things. You see that little branch right there coming off of the inferior alveolar? Just before the inferior alveolar goes through the foramen, it sends off that little nerve right there, which is called the nerve to the mylohyoid. It comes down and supplies the mylohyoid in the anterior belly of the digastric. So you actually paralyze those two muscles with that block as well.
What's that nerve called?
The nerve to the mylohyoid. It gets not only the mylohyoid, but the anterior belly of the digastric, just in case you're on Jeopardy, that sort of thing.
Is it just because they inject in that whole area that sometimes you get numb right here too?
No, actually, when it starts getting numb up in here, the stuff is from here, it's infiltrated up into your maxilla,
Okay.
and you're getting the infraorbital nerves. They put a lot of stuff
Yeah,
in
they'll
there.
come in and say, "Are you numb yet?" And I say no, so they'll put some more in there. And I say,
Yeah, if they do the injection just right, then you're gonna lose sensation to the teeth, the chin, and to the tongue, but nothing else. Actually, there is one more thing, but I'm not gonna bother telling you. Yeah, I gotta tell you. There's another nerve that attaches to the back of the lingual. That nerve is called, we're gonna see it when we do the ear tomorrow. It's called the chorda, C-H-O-R-D-A, chorda tympani. Chorda tympani. It's a branch of the seventh cranial nerve that actually attaches to and runs with the lingual nerve. Now, what that nerve does is, let me tell you what it does. It provides visceral efferents to the submandibular and sublingual salivary glands. Remember I said the seventh cranial nerve provided visceral efferents to the lacrimal and to the submandibular glands? It's also sublingual. You also have the sublingual salivary glands. So the chorda tympani provides visceral efferents to the submandibular and sublingual glands. It's 7, cranial nerve 7. It just runs with 5. The other thing it does is it transmits taste from the anterior 2/3 of your tongue back up to your brainstem. Taste to the anterior 2/3 of the tongue and visceral efferents to the submandibular and sublingual salivary glands. So when you go to the dentist and they put that injection in there, you're going to lose function there too. You're going to lose taste to the anterior 2/3 of the tongue. You're going to lose visceral efferent or motor supply to your submandibular and sublingual salivary glands. You're going to see this again tomorrow. So don't
This is
get.
all the chorda tympani?
That's, those two things are transmitted over the chorda tympani. Motor or visceral efferents to the submandibular and sublingual salivary glands, and taste from the anterior 2/3 of the tongue. Here's the buccinator right here. The purpose of the buccinator, even though it is a muscle of facial expression, understand that it helps keep your cheeks tight when you're chewing. It keeps the food bolus between your teeth. It helps, it's not a muscle of mastication, it's a muscle of facial expression. Puff out your cheeks. But it also helps keep food between your teeth. Here's the here's the lingual nerve. There's the small, tiny chorda tympani joining the back side of it right there. There's the inferior alveolar nerve. There's the nerve to the mylohyoid. See, now it all makes sense. You have a whole bunch more branches of V3. These are all V3 branches. There's V2 up there. V3 is right here. You got this branch here called the buccal nerve. It looks like it's going to the buccinator. Is it? This is the big question. Is the buccal branch of V3 supplying the buccinator? No. The buccinator is facial expression. It's 7. What would be the buccal branch of V3 going to supply? What would it go to supply? Your buccal mucosa inside your mouth. That's the buccal branch of V3. All of these things come out through that little foramen ovale in the base of the skull. You see this large artery coming here off of the external carotid? That is the maxillary artery. The maxillary artery is going to dive through this fissure here and enter the nasal cavity. You have to hold a skull to really appreciate this. It'll dive through that hole there to enter the nasal cavity. Because there's the maxilla right there. The nasal cavity is on the other side of that. If we look at it here, here's the maxillary artery. It's got an inferior alveolar that goes with the nerve. It's got a middle meningeal that's going to go up. Where's the middle meningeal? I can't see it where it is on this slide. Middle meningeal goes up right there, deep to the pterygoid. It will actually enter the skull through foramen spinosum. I'll repeat this again tomorrow. The foramen spinosum, I said, was in the sphenoid bone. It transmits the middle meningeal artery. It goes to supply your meninges, which is right here. It's that blood vessel, when it dilates, is what produces your headache, your migraine. That's predominantly the one. You have small branches that go to the muscles of mastication, and the maxillary artery ends as the sphenopalatine artery that goes through there to supply the inside of the nasal cavity. When you pick your nose and you start a nosebleed, that nosebleed originated from way back here. I think this just illustrates more of what I said. One thing, though, that this highlights, though, is that the muscles of mastication are all branches of V3. It's only the mandibular division that gives rise to the motor nerves. V1 and V2 are purely sensory. V1 and V2 are purely sensory. Only the motor root comes off of V3 to go to the pterygoids, the temporalis, and the masseter. That enough for today? All right. Let's go see what's in the lab.
The Freeman's. Okay.